To learn more on this, we have with us Dr. Joe Thomas, today's keynote speaker, who will talk about comparative analysis of the leadership challenges that exist between public and private sector in the context of healthcare and more. Sir is an accomplished institution builder, academician, diplomat, and a global leader in public health, rights, and social development for more than 25 years. In addition, he has excellent experience in the administration and management of complex multi-stakeholder projects of high-level strategic engagements, and proven expertise in cross-cutting multicultural work environment in developing countries of Africa and Asia regions. He has led 11 countries' projects on HIV-related stigma, discrimination and rights, aging in 22 developing countries. Sir has also worked as advisor and consultant to WHO on several projects. Dr. Thomas worked as the executive director of an intergovernmental organization of 26 governments, partners in population development, PPD. In this capacity, he presented PPD at the UN General Assembly in New York and the World Health Assembly, WHA in Geneva, spoke at the UN General Assembly on Sustainable Development Goals, Migration and Refugees. A plethora of publications and research projects. Currently, Dr. Thomas is the editor-in-chief of Cogent Public Health, a Taylor and Francis journal. I extend a very warm welcome to you, sir, on behalf of the Faculty of Management and Commerce and all of us present here today. We are indeed thankful to you. We are indeed thankful to you. Despite your busy schedule, you have taken time out to be with us. Kindly come on stage, sir, to address the gathering.
Good morning, everybody. Thank you for the generous introduction, and thank you for inviting me for being here. And also, in the diplomatic parlor, we say all the protocols are being observed. So I'll not leave anybody not particularly mentioning by name, because I didn't manage to go through and find out the names of everybody. My apologies. So the shortcut is all the protocols are being observed. Thank you. But at the same time, I just wanted to thank the students who are here. And my presentation is about public sector, and particularly health in the public sector, and what are the leadership challenges, leadership lessons from public sector. We talk about India being a global economic power, but we have to keep a close eye on the issue of public sector and how we are going to strengthen, what lesson we should be learning, and what refinement we may have to do. And my understanding is that my audience is managers, leaders, administrators. And to begin with, one of our most accomplished academic qualifications, MBA, Masters in Business Administration. I used to wonder, you wanted to make them administrators, not even manager, not a leader? So I would begin from that a particular observation, my presentation. When I started preparing for this session, I thought I'd make a slide. Then I thought, no, my presentation and a detailed paper and the slides, I'll put it on my web page and also my Twitter. So I request you to take a look at my web page if you're interested in getting the full text of my presentation and also the slides. You can download it later on. After my presentation, upload it and also announce it on my Twitter account. And let me revisit the idea of administrator, manager, and leader. You're trained as an administrator, but you'll start working as a manager. But you should strive to become a leader. So my presentation today is about leadership challenges, what lesson you can learn as a leader from the public health sector. We may hear, all my esteemed colleagues are here from the organized management sector, and I just broadly use the brush to say that the organized management sector, and not getting into the details, because somehow when we talk about management experience, we tend to forget about the management experience coming from the public sector. And when I talk about public sector in the public health point of view, even that there are two streams of public health leadership. One is the government-sponsored public health programs, large hospitals, public hospitals. Also there are, beside or beyond the government sector, there are private enterprises, individuals, practitioners, and they work in the public health sector. And that presents some unique leadership opportunities. And I did a review of literature, rapid review of literature. There are many issues came up. So I thought, and also from my own experience in working in different countries on the leadership level, and I never worked in a private sector as a choice. And I had an opportunity to work in different countries on the senior leadership level. On the public health sector, as a choice, I took that. That doesn't mean that that's not a good or bad. It's an opportunity, it's a challenge, it's a personal value system. You're trying to deal with it and trying to learn with it. So that gave me a great opportunity for learning, a unique opportunity. And many of my research opportunity, I got that opportunity to look at the possibilities of the data collection, the data, and evidence-informed decision making. It comes from unique perspectives. So again, I emphasize where I'm coming from. And the evidence experience I'll be bringing from my own experience, and mostly from the Indian health sector, and also from many other developing countries. I worked in East Timor, I worked in South Africa, I worked in Australia, I still work in Australia, and also a couple of African, Rwanda and Burundi on the health system. So, and also I worked with an advisor, as an advisor to 26 health ministers in the country, including our health minister and the Chinese health minister. So my great lesson was sitting with the Indian health minister and Chinese health minister and talking about health system challenges in the presence of Bangladesh health minister. So I'll begin my presentation with a small story. So I had a great opportunity and honor to have breakfast with the three health ministers. I'm not mentioning the minister who it was. So Indian health minister, Chinese health minister, and Bangladesh health minister. So they were talking about health financing. Our meeting was about health financing at the SDG, Sustainable Development Goal financing on health sector. So the issue of financing came, then they said all of them they had rely heavily on the World Bank grant and also World Bank loan. So that's the main issue. So when they said their experience of dealing with World Bank consultants, because we know that sometimes the World Bank country director, World Bank consultants, they exercise exorbitant power on the governments. So I'm not getting the details of that. So they were talking about this power dynamics of how to deal with World Bank consultants. So one of the issues the World Bank consultant put forward is saying that the public health sector, doctors won't attend their clinics. Being absent from the work is a serious issue. So they requested that all this government should deal with it. So the Indian health minister said, yeah, I know that it's also a serious problem for us. So then they asked, how do you deal with it? The Chinese minister asked that. So the Indian health minister said, no, I don't get into that because health is a state subject. So I don't get in from Delhi. Let the state deal with it. I know it's a problem, but we keep on negotiating and we keep discussing about it. But this is one of the administrative challenges I had to deal with it. I don't have a solution. But the consultants said, we have almost 30–40% of the doctors that never attend on time. So this is a serious resource misutilization. That's why they looked at it. And the Bangladesh health minister, he narrated the story. That's the most fascinating one. He said, he himself was a doctor, the previous health minister. So he said, I tried many things. I tried personally, I tried to ask them to come for it. In Bangladesh, there are only 60,000 medical doctors, trained doctors in the entire country. Out of that, half of them are in the government sector. But most of them, they want to work only in Dhaka, not in any other district, not even forget about it, they have 1,000 community clinics. And out of the 1,000 community clinic, incidentally, 100 community clinics are given by Government of India. I had the privilege to establish, build it, and hand it over to them. So the Bangladesh minister said, I know this issue. Then he asked the consultant, you suggest a solution, I'll go by that. So the consultant, he's a Britisher, he said, you should have an attendance system. Fine, go for it. So how do you do that? You should have a swiping system. You should have a card for electronic system. So he said, go for it. You allocate the resources from this loan you're going to give us. So minister said, I know this is not going to work from the day one, but he didn't say that. He said, so they called for a tender. They got this electronic swiping machine, that, what do you call that? The what do you call your biometric, sorry, thank you for that. The pre-biometric time. So it is just swiping the card. So they issued the card for everybody, and the minister and the consultants, they were sitting in the morning in the minister's office because they have a system. Minister can monitor them, each hospital, how many doctors came, what time, all that. He was very fascinated. And the consultant was super excited. His project is running finally. And they started coming in, and by 10:30, 80% of them are present. So minister said, I know my people, there is something fishy about it. So what he did, he called up one of the administrative officers, not a doctor, in one of the remote hospital. He said, and he called, he knew this person personally. He shouted at him, he said, what did you do? Then he said, sir, it's not me. And the doctors gave me the card and I swiped it for everybody. So the public, and then the doctor said, then they said, this would happen. Then they said, okay, then what you do? And doctors gave the card to the attendant. You swipe it for us, and they went their way. So this is one of the examples. Then I can go on. Then the Chinese minister said, that's the most fascinating thing. I was waiting for the Chinese minister's answer. He said, I don't want to worry about it. That's taken care by my party colleagues. Party secretary will take care of it. Local branch secretary. So 3 different systems of how to deal with a public health lesson, management lesson. How to manage. So the lesson is that one is a cultural specific, and the cultural specific is circumventing some of the issues. So this is a lesson, but this lesson is not added to my level lesson. I just as introductory one. And again, when I talk about health sector, one is, if you use Indian as an example, Indian public health sector, it's completely disorganized or largely disorganized. So in a disorganized sector, are you an administrator, are you a manager, are you a leader? So for me, the difference between administrator, manager, and leader is administrator deal with one department, how to fix your laptop, maybe the desk is not in size, that's administrator's job. But the managers worry about today, how many people came for the work and what to do, how do I pay for the salary, that's the manager's thing. But leader will start worry about tomorrow. And tomorrow, how many staff I need, tomorrow, how I'll generate resources for my program, and tomorrow, how many staff I may need. So the leadership is the crux of the entire spectrum. So this leadership challenge is what, as a student, you should not be confined your aspiration only as an administrator, only as a manager. If you want to make changes in the society, you want to make any impact in the society, thrive to become a leader. That leadership, think about inspiration and example and experience from non-traditional areas of leadership. And that's one of the areas you should look forward is the public system, public healthcare system, because that's fascinating. Let me come to that. So number one, the managing the idea of health. And health is looked upon 2 ways. One is, health is a commodity. If you have money, you buy the best medical care. But at the same time, those who are interested in looking at the Indian Constitution, the right to life is a constitutional right for every citizen of the country. Now, talking about Constitution is always politics, but health is politics, so I'm not shying away from that. So I'll be quite happy to talk about politics of health. Politics of health is about who gets what treatment, how they get it, how long they're going to survive. So that's the politics of health. So in that first thing, I mentioned that the idea of health is a consumer good, or it is a right. This is the challenge coming up. So the leadership, you look at it as a health as a human right. So how the state ensures the right of the individuals, the right to survive, right to life. That's the basic essence of the right to life. But whereas increasingly there is a separate another idea of health is coming up, life is a product, it's a commodity. You pay, you get the right. You get the right quality of care, the amount of care, or maybe the life expectancy, you increase it. But this is one of the basic challenges of the leadership. In the Indian Constitution, the state responsibility, again the health, there is a federal and the state responsibility division of labor. The health is in the state sector. The federal state's responsibility to take care of the health and well-being of the population, not the federal government. Federal government should worry about the India-China relationship, India-Pakistan relationship, not necessarily on the health. So this is the interesting part of it. But then the issue is that a political consensus on what is health. Health is a commodity or health is a human right. This is one of the ongoing dialogue among all the political parties. And when I say political parties, the political parties manifesto what they talk about health. I did an exercise of looking at the manifesto of 24 parties during the last general election. How many parties looked at health in the constitution, their election manifesto? As a management students, I would request you to, when you say political parties manifesto, look at what is their commitment about health and well-being and what leadership they're proposing. To what extent they're promoting health as a commodity, what extent they're promoting health as a right. Because this is essentially driving from the constitution issue. Your leadership challenges is going to be shaped from setting up this particular problematic issue. But that is, I would say, in the Indian context, it's an ongoing dialogue. The Indian politics is an ongoing dialogue on many issues. You settle certain issues. We settle it on the street, some we settle it on the parliament, and some we settle it on our vocal power. And there comes a leadership. Managers, quite often, they may not be able to settle it. If you are a leader, you may be able to contribute towards settling some of these leadership issues. And the second is about collaboration and communication. These are the essential nature of public health leadership. And this collaboration and communication, it prominently came into forefront during the COVID time. The COVID response was a response of collaboration. We know that even the police constable became a health worker. He used to stop you and ask him to put the mask. The risk and benefit, I'm not getting into that. A large spectrum of people who are not traditionally involved in the health sector was called in or driven into health sector leadership. The ordinary constable, even sector magistrate, a local high school teacher became a health magistrate, sector magistrate, community health workers, ASHA workers, all of them they came on overnight health leaders, but without any preparation. So as a manager, as leader, this is one thing you have to remember. What are the collaborative systems you may think about it? And what are the communication channels you have to communicate the challenges you have? So cultivating systems of collaboration, identifying your partners, identifying stakeholders, constantly reviewing it, and also constantly looking at the communication possibilities, and not even saying communication channel, because now you have a chat bot is there to tell you what to do. So, but there are new technologies coming from communication. As a leader, you should be aware of the changes in taking place in the communication area and the collaboration area. This is the second challenge, I would say, which is coming from the public sector. And the next is about the fourth one is that data-driven or data-informed decision-making. And in the public health sector, the data, when you talk about data about health, data about individuals, data about epidemiological transition, and data about the demographic transition, and all this, we don't have a system to rapidly discover this. We have to scan it from different systems, different areas, and the different quality of the data. So as a leader, you may have to cultivate your source of information, source of data, not information. So if I look at health sector, health data coming from, in the government sector, you have patient data. But the patient data is telling only a small fraction of the full data requirement. So you may have to look at what is the disease changes taking place. The Indian context, earlier people used to die of epidemics, cholera, maybe typhoid. There are pandemics used to kill people. But today, there are non-communicable diseases are increasingly killing Indian population. Cardiovascular disease, diabetics. So the disease spectrum is changing, disease profile is changing. But at the same time, if you look at the cost of it from the leadership point of view, the cost of just treating the diabetic treatment in India is going to be several $1 billion. That's just cost of one medication. But we know that these are preventable diseases. This can be managed through the systematic intervention. But from a leadership point of view, local leadership, national leadership, even the institutional leadership, what you contribute towards preventing or managing non-communicable disease like diabetic disease. And why I'm emphasizing is that increasingly young people are getting affected by non-communicable disease. And see, if you look at again, there are other nuances in the leadership. There are gender variation, there are ethnicity variation, linguistic variation, geographic variation. Where you're born and brought up is going to affect your quality of life and how long you're going to live. Your life expectancy is largely influenced by which part of the country you're going to live. You're near the cities, you have maybe a better access. If you plus you have money, you have the best medical care in the world, you can get it in the country. But you're in the remote hilly area, remote tribal area, your chances for living life expectancy may be 50, 55, 60. The general life expectancy can go to 85 for some population, whereas 50 for some population. So this is, I would say, national level, this is one of the major leadership challenge. But what is this was go to private sector? Each private sector may be asked sometime what is your contribution to health and well-being? Because any institutional setup, the ultimate contribution is well-being of the society. Any private sector, you may say that profit maximization is one of the critical indicators to assess the validity of that particular institution. But there are, beyond profit maximizing, there are other social responsibilities. One of the social responsibility of the leaders is contributing towards public good. So this will be called upon all the managers. As a manager, what public good you're creating, what public good you're maintaining it, and what public good you're nurturing it. This issue comes up. And the next challenge is about preparedness. Are you prepared? Prepared to deal with unexpected challenges. On March 24th, our Prime Minister came on the TV and he said, we are going to close down the country. Are you prepared? I don't know even 10 people were not prepared in the entire country of 1.5 billion population. So the preparedness for unexpected, came straight on our face on 2020, March 24th. And just give an example about it. None of the systems were prepared, not public health sector, not private sector, policymakers, institutional builders, nobody was prepared. This gives an important lesson. Are we prepared for the pandemic? Are we prepared for the natural calamities? How that is going to impact on your leadership challenges. The concept of preparedness should be the one who is going to worry about when you sleep, or your sleep should be disturbed by are you prepared for tomorrow's leadership challenge. This should be one of the major challenges for the leadership. I'm not getting into the details of it, I'm just highlighting some of the issues about it. Are we prepared? So that should be one of the slogan for each manager should be worry about. And the next one is, I would say, the continuing improvement. Continuing improvement of the systems, continuing improvement about understanding about the situation, and the continuing improvement about the readiness. And I can go on the issue of continued improvement. But think about as a major leadership challenge, our ability to reinvent and the ability to continuously improve about our performance as a leader. So this is another major challenge. The next one, the seventh one, I would say that promoting innovation in public sector, public health sector. We talk about the management today, the mantra is innovation. In academic circle, we say publish or perish. In the management sector, we say that you innovate or perish. Innovation is about survival. But how do we innovate in the public health point of view? So what I notice are there are two kinds of innovation normally takes place in the public sector, and particularly in the public health sector. One fine morning, health minister get a brainwave. from a top-down innovation in health. That's one way of innovation takes place, that the minister may have advice by the minister's health advisors. Because I worked with many health ministers. If you want to work with the health ministers, you have to work with their advisors. If you want to get through a policy change, if you can convince the health advisors, then you have a minister may say yes or no, but the advisors, they repackage it. So the innovation in working with institutions and innovation in identifying how policies are being made, and innovation in understanding how systems should work in implementing innovation. And also from a management point of view, the innovation is identified as mostly a technological innovation. I would say the innovation of ideas. Promoting innovation of ideas is going to be a critical challenge. And how do you create ideas? How do you pluck ideas? That should be the leadership challenge. In your system, your environment you work, how do you promote innovation? Innovative thinking, innovative technology it's a different thing. That's a technologist leadership challenge, creating technological leadership. As a leader of institution, you have to constantly think about how do you promote innovation. You yourself may not be innovating, but you're facilitating innovation. Being a facilitator of innovation is the leadership challenge. This is what you're noticing from the public sector. Innovation in terms of, for example, how do you create a rapidly response to COVID pandemic? There's a huge segment of innovation took place on patient management. You created temporary hospital tents. You created temporary sheds all over the country. And you created people sleeping on the street. That's not innovation. But at the same time, we notice that there are triage doctors. Doctors will consult the doctor on an ambulance, not in the hospital. This nobody thought about in the COVID. The COVID time they were forced because there is no place for a patient to bring it in. So the doctor go to each ambulance and see that who is about to die, so they get a priority and they bring them in. And at the same time, we notice that in the medical sector, what we discovered or created something called task shifting. The nurses increasingly playing the role of physicians. And in Australia, where I come from, we have trained practicing nurses. Practicing nurses provide primary health care. And why it happened? Because Australia, the trained doctors is a scarce product or scarce commodity. So they discovered retasking, re-innovation, innovation in redesigning the task of the physicians, and 25 procedures can be provided by a nurse. The nurse is called practicing nurse. They registered nurse, they can set up a clinic, nurse clinics for primary health care, like travel medicine, vaccination, injection for the children. There are 25 medicines they can prescribe. So this task shifting is an example of how innovation takes place in health sector. So this is, I can go on what kind of innovation takes place in health sector. Take the case of vaccine research. In the vaccine implementation, normally you have to go through a clinical trial. And many people asked, the COVID vaccine didn't go through the long vaccine trial, and how did you manage to do that? Is it ethical? But also we have to remember that innovation behind new opportunities for leadership and technology. The COVID-related vaccination data, your real-time data on your laptop or your mobile phone you have. So we can see 1,000 patients, how many side effects came, million patients, million people who received vaccination, what are side effects. Real time you can see, the minister can see, the chief medical officer can see that. So this is the way we managed to make a shortcut in the long longitudinal clinical trials for the vaccine efficiency and efficacy. So this is an innovation. We never thought about this is possible. So the opportunities, and be ready for that. And the public health sector gave the opportunity for innovation in how the medical services are rearranged, how the medical technology is promoted. And also in the public sector, we have an issue of procurement. We know that public procurement, you have to call for tender, and the tender timing is minimum 3 months to 6 months, then wait for the lowest tender. Lowest tender means you're immediately compromising the quality. But you pick up the highest tender, you will be immediately, your reputation is at stake. As a leader, if you pick the based on your consciousness, you know the best quality is going to be provided by the highest bidder. But if you pick that, your neck is on the cutting board. And this I experience. Knowingly, I know that how the contractors can, they can fix the system, and all the 5 contract is given by the same contractor, and they give the lowest. And the lowest trend is the quality, most quality compromised, but you are forced to go for the lowest bidder. The lowest bid, after 6 months, they will go bankrupt knowingly, and you advertise it. So this is the one lesson we learned from the public sector. But fortunately, as the United Nations agency, I had the privilege of what we call it as selective tendering process. But imagine that when you call for a multi-million-dollar, you take a decision about not going for tender, and you can do a single source procurement as an administrative leader, but at the great risk of your reputation. We easily can say you took the bribe, and that's why you give the commission, you give the tender. But then we created a new system. We created a consultative body to decide and evaluate the tender. A public process. Anybody can come and talk about it. We are taking the largest tender because of X, Y reason, and that may be even 20% more than the market rate. And this also I learned. When you say that, I was asked, you gave a tender 20% more than market rate. That factor, that slogan, that statement, I never heard of, never thought about it. And I asked the contractor who received the contract, and I've been told that you're getting 20% more than the market rate. The contractor said, yes, sir, it is true. And I almost, literally, I was falling down from my chair. Then I asked him, how do you explain it? He said, sir, the so-called market rate is fixed about 4 years ago. You don't revise it every year. So this is 4 years ago, and today's market rate, that's almost 15% immediately gone. Then I am a businessman. I need minimum 10% as a profit margin to make some profit out of it. And then he told me that, sir, then of course, speed money. First time I'm hearing this word speed money. I said, what is the speed money is about? Then he laughed, sir, you don't know about speed money. I said, no, I'm working in Bangladesh first. I worked 8 years in Bangladesh. No, I genuinely said, I don't know. But he never believed it when I said, I don't know speed money. Then he said, sir, I'll bring my bill for signing it. So I had to give you something. I said, what? But sir, I know that, you know what it is. I said, please tell me what it is. Then I said, see, I'm not going to take a cup of tea from you. Take it granted. The moment a tender document comes, I'll sign it if everything is compliant. And also I can do something. I can clear all the bills within 10 days. If I cannot comply and check everything, I'll give you 80% of the bill will be cleared immediately, and 20% I'll hold it for the inspection. Then he said, sir, you are not the one who is going to sit and review it and write it. Your staff is going to do it, isn't it? I said, yes, I know. I trust my staff, and they do the due diligence and send it to me, and then I'll approve it. Then he laughed, sir, they are not going to do it unless I give something to them. This is what the idea of speed money. Then I said, sir, you are new to Bangladesh, you don't know what is the consequences. I said, okay, what you do, sir? Then he said, I cannot take it back. This money, what I do, I'll keep it as a reserve. This is something I heard, your speed money is kept it a reserve. I was thinking, my goodness, how do I was trying to process in my own head this, how to deal with it. And the first day, the foundation for our Secretariat building, about a $14 million grant. And the grant is given by China and India. And that time the body was chaired by Indian Health Minister. I'm not naming the Health Minister. So I came to Delhi to invite him because it's a very great honor that I wanted to invite the Indian Health Minister, come and do the foundation stone. He gave me an interesting political advice. He said, Joe, I'll come there, but invite the Prime Minister as the one who's putting the foundation stone. I said, sir, but you are the chair. He said, I'll be there, don't worry, I'll come. But if the Prime Minister comes, many of the local problems will be taken care. I said, like what? Your electricity connection, water connection, your access road, everything will be taken care of. I said, my goodness, he is a political leader. So then he said, don't worry, I'll call up the Prime Minister, I'll arrange it. Actually, that's what happened. And again, my leadership lesson I learned by coming to that. Anyway, I had 2 more I'll learn. So then they agreed that he called up the Prime Minister's office, Prime Minister's office, Bangladesh Prime Minister's office staff came to me. We discussed about the logistics details. And this property is a half a hectare land. So I got it from the ministry, Bangladesh government. Many people ask me how much money I gave them as a bribe to get this much land in the prime area. But the story was that this land was a small pond, which I didn't realize. So you had to fill it in. So it was a small pukur in Bangla. So it is known as a public place, a dumping place. So it became a mosquito breeding place, half a hectare land. It's a pool. But the minister gave that property because certain other political maneuvering behind it. I'm not getting into all those details. So the Prime Minister's team and came said, okay, Prime Minister happy to come and then this, but we have to clear this land. There's a slum area, they have to clear all that. And most importantly, they said, but this is an isolated area, Prime Minister is coming, you have to build a toilet for Prime Minister, temporary toilet. I mean, it's a genuine request. What do? I cannot say that you shouldn't have a toilet for the Prime Minister. I said, fine, go ahead. Then he said, this person came with a drawing, everything came, and the budget also. He said, it's only about $85,000. And then he said, we dismantle it. So I was thinking that in my budget, I was thinking, where do I account for this? So then, as a chair, I thought maybe I'll get a special exemption for the chair. The Prime Minister's toilet nowhere in the place. He again gave me a political advice. He said, why you should have a foundation stone laying ceremony and the location? You do it at the hotel where we're having our ceremony. This also I never thought about it. Adaptation of the situation, as a political advice, give me that. So don't do the ceremony at the location. It's a security issue. You cannot manage it. It will be all your headache. You do it at the hotel where we have this interministerial meeting. And our foundation stone ceremony was done at this five-star hotel, and they created all this ambience, and a stone was, and all this, the curtain and all. And then we discovered that you had to give a refreshment. You had to give all this curtain, you had to bring a concrete slab and all. So the hotel person said $8,000. My goodness, where do I do this $8,000? Then I asked our contractor, sir, please help me with it. Sir, your speed money is sitting there. So my speed money was used for the inaugural purpose. There's a story goes on that. So I just give an example of how we learn lessons from the public sector. How do you deal with it? And also location specific. And I was mentioning about innovation and promoting from the leadership. So innovation in the leadership management style. And your foundation stone laying ceremony, and then I realized that whenever I see a minister putting a foundation stone, I look at the picture carefully. Is it really at the location or is it the five-star hotel? So at the next point I just wanted to highlight is about equity and understanding the social determinants of health. In the Indian context, India is going to become one of the fourth or fifth largest economy in the world by 2030. But at the same time, if you don't take into consideration of the equity, inequality, particularly in the area of health sector, we have a serious issue. I can tell you a sample what is happening. A few months ago, about a year ago, there is a selection of our soldiers, recruitment for the Indian military. We have this shorter military version, and the youngsters went for the rampage all over the country, not in one state. In practically all the states, they went for the rampage. Literally, there is a massive destruction took place. It is not an organized program. If you look at carefully, this youth unrest and its expression was not an organized expression, not even by any political parties. It's a spontaneous response of the young people. A similar issue can happen in the area of health. A similar issue can happen in the area of a lack of opportunity for the youngsters, even when we become a number 2 and number 3 of economic expansion. So this is more prominent in the area of health. And today, you can die if you are not rich enough to pay for the health care. But at the same time, some of the best medical brains are in the public sector. Private sector medical colleges brings out the best medical doctors. Private hospital professors, some of the best doctors here. But at the same time, we don't have a system to translate that into actual action. The health inequity, let me give my practical experience. I did my fieldwork extension in West Bengal, in Purulia, Murshidabad, 4 districts. I looked at the issue of neonatal mortality. Why children are dying before they reach the age of, before they reach the 29th day. So we looked, what we looked at is that I looked at the reasons. I interviewed the ASHA workers, not anyone else. ASHA workers, then there is in public health we have something called postmortem, on a verbal postmortem we can do that. By questioning you can find out the reason for death, not the physical postmortem, verbal autopsy. So verbal autopsy, normally we interview the local people, local panchayat chiefs, the member, the representatives, ASHA workers, ANMs. So ASHA workers, I asked them, do you recollect when was a child died in your area, a neonatal child died? She said, I remember clearly. Then I asked her what happened. She said, the last case was I knew that it was a difficult pregnancy, and I recommended them to go to district hospital. And this is a tribal couple, and he pedaled the wife, the back of his seat, the cycle, and went to the district hospital, 15 kilometers there, bicycle. She was the last stages of pregnancy. He went to the doctor. Doctor said, why you came? Doctor said, the ASHA worker said, my due date is such and such date. The doctor said, who is she to decide your due date? What she know about your due date? But ASHA workers are nowadays reasonably trained about basic primary care. So doctor said, no, I'll tell you, you go back, you come back later. Then he calculated, he should come back after 15 days. So he didn't have money. Overnight they started cycling back. But what happened is in the middle of the nowhere in the jungle, this girl delivered and didn't know what to do. That child died. There's one example. Then I asked the ASHA worker how you could have prevented it. Then she said, if at all the doctor could have called me or I could have talked to them, then why should I went to talk to them? I said, sir, I don't have mobile phone. 50 rupee you get a mobile phone, the cheap mobile phone. We have all this technology. ASHA workers, they don't have now this coming up, one of the smartphones are coming up. She said, I could have called up, I could arrange a taxi to send somebody. This word said, a mobile phone could have saved that child. Then the next one I asked about, what is the case? She said, we knew this girl and they were working, she was an agriculture worker. So the family decided that they'll do the last day of cropping. They do the cropping. So they calculated maybe one more day she can help us in the agriculture thing. And then her pregnancy, they started labor pain at the early morning, 3 o'clock. So there is no transport system to transport to the hospital. Then she said, there is no car. If at all I had a mobile phone, I could have called for taxi. Again, a mobile phone could have saved a life. So we calculated about 26 reasons for why children die. None of this was a technical reason. All logistical reason, policy reason, basic issues about, Then I calculated how much money we would have required to save these 26 deaths. Maximum, if you had 1,000 rupees per head, we could have saved this. So this is what we're talking about national level. So what is innovation? Innovation sometimes not coming through technology. We have some of the public sector now, the trading hospital, there's the Delhi Medanta hospital is publicly traded. I look at their share prices daily. Not because I'm investing in the share. I look at the value of the cost of Indian life that is reflected on the share market of the Medanta hospital. Medanta hospital, there are 600 million public sector, but that the 300 hectare land, the land is governed by the government. With a view that they'll give over 20% of the bed to the public enterprises. But nobody won't dare to walk into that hospital. I've been to that hospital 10 days. I afford to go there, but I did a mistake because I told them I had international insurance. That is my stupidity. They said be there for 10 days. But that time I didn't realize the significance and nuances of that. Then I noticed that who are the patients coming here. Sorry, ma'am. Okay, last one more. Oops. Maybe I got excited with my story. Maybe that's also innovation. If you can get excited about what you do, probably as a leader you should get excited about what you do on a day-to-day basis and your capacity to communicate that excitement to others. And what I mentioned about if you don't look at the issue of equity, even the private sector, even within your environment, how do you contribute towards equity? And be aware of the consequence of the inequity. And so this is one of the lessons we have to learn. And the next one is about adaptability. How well you are capable of adapting. For example, now I have to adapt myself to reduce the time. So adaptability, be ready to adapt. That's a leadership challenge. The last one is about resource management, the 10th one. Sorry, not last but one. The public sector, you know that always there is a lack of resources. I told you that you don't have money to buy a 50 rupee worth of mobile phone for an ASHA worker. At the same time, we don't have money for many other things. I'm not comparing that. The access to resources in some of the areas, particularly in public sector, is a constant challenge. And we joke about it in the health budget or the state budget normally depends upon the health secretary's vocal power to negotiate with the central cabinet secretary how much money we get for the site. Not even the health minister. The health secretary go and argue and advocate for them the resource allocation for the state. So constantly keeping an eye on the resource requirement, the resource management is a leadership challenge. And the last one is that the issue of governance. If you look at the Nobel Prize in economics, probably the next Nobel Prize should come in the innovation in governance in the broader sense. The governance models, we have very limited innovations. The models, how do you manage your systems? How do you manage your innovation? How do the entire systems are held together? This is a challenge for both private sector, public sector. What innovations you can think about your governance system? Today we know that you have a chairman, we have board members, you have 8 board members, you have a structure of it. Can we think something new? Horizontal structure, vertical structure, no structure. Maybe our thinking is becoming stagnated. There's a block about looking at governance. And this is very important in the health sector. Health sector almost in a dissipated governance. There's a health minister, but the administrators go on the other way. The health bill is normally drafted by the health administrators. Minister, look at, he'll ask, everything is all right? The health secretary and the health administrator, so everything is all right. Minister says yes, and now recently within the last 2 months, there are 2 states that cleared their state health bill, Kerala state bill and the Rajasthan health bill. So I know the process behind it. Both ministers had no clue at all. I'm sorry to talk politics. But when the questions asked what is the principle and value system behind this this law, see, for example, health is a human right, but Rajasthan, there's a Rajasthan health bill for health right bill, that's the name of that, in Kerala public health bill. So we expected that Kerala bill may be a human right bill, but the other way around. But the issue is about governance. Public sector, private sector, there is a lack of, or maybe I would say the poverty of ideas in governance. One of the leadership challenge I would say that look at the governance and think about it, be innovative about it. So that could be your glory, a serious work on innovation. And I'm quite sure that my business colleagues will agree to that. They're looking at the issue of governance, what innovation we can bring in, not on technology. Innovation in the idea of governance. So this is coming prominently from there. So I conclude saying that I hope I'm talking to the leaders, not managers. I hope I'm talking to administrators, but leaders. So thrive to become leader, not manager, not administrator. This is my message. Thank you very much.